Sorry. If you are done and you want to take some time, we will come back together at 9:05, like I said, and we will review the exam. So if you want to stand or walk around and you're done, feel free. But we'll make sure we get everyone back in who's probably waiting until 9:05 before we review together. But we'll go through all the answers. Is anyone still working on their exam? No. Okay. How'd it feel? Okay. Overwhelming, maybe? Yeah. Okay. Some good areas, some not so great areas, probably. Yeah, absolutely. That's typically what I see and what I feel and what you will feel on exam day is you'll go through some vignettes and you're like, oh, got this. And then you'll hit some vignettes and be like, I've never seen this in my life. And that's totally normal. And they'll probably either one of two things will happen. Everyone will have that same experience and those vignettes or those questions will be thrown out. Or that's just one of the few questions you missed, and that's fine. Again, it's not a test of accuracy. It's a test of numbers. It's can I get the majority of them right so I can pass, knowing that you're not going to ever probably get them all 100% correct. Some questions are just not written well. And I actually threw out a few questions myself before administering the exam because they weren't clinically relevant. So. Meaning they were just wrong, the questions and the answers. I don't know what else to say. All right. I'm turn off my sound and get those Hello. Oh, thank you. All right, let's review some stuff, shall we? Let's move forward. So you took your first, or maybe not your first, practice exam. Some of you said you felt okay. Some of you said you felt unsure. I'm sure there's a bit of combos of both, yeah? These are old NPLEX questions, yes. Yes, and so that's exactly why that's on. That's a great adage, and we'll hit that when we get there. But that's that type of a question would be thrown out because it's not an appropriate NPLEX 1 question because it's diagnostic, but it has been on the NPLEX 1 in the past. So so what she was mentioning, I'm sorry, remind me of your name. Laura? Oh, so what Laura was mentioning is that there was at least one question that was diagnostic on this exam when it comes to Patrick Faber's test, you know, cross your knee, checking for hip osteoarthritis, et cetera, that's diagnostic. That is not something that we'd see on NPLEX 1, it's something we'd see on NPLEX 2. That being said, it's been on NPLEX 1 in the past, and it's been likely thrown out. I can't confirm that because I'm not involved in that process. But that would be likely a test question would be thrown out and not included. So whether you got it right or wrong, those type of questions you can assume will get thrown out, but you'll see those on the exam. So when you do come across a question like that on the test, answer it to the best of your ability, but know if it's diagnostic, it's probably not going to be included in the final tally score. Okay, yeah. 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 These, I would say, are pretty close to accurate of what I've seen on the exam, if not a direct replica of what I've seen on exams. Yeah. 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 These are a pretty good representation of what you could expect to see on the exam, how they're written, how they're worded. Some of them I have seen on the exam before. Yeah, absolutely. Great question. I can't guarantee anything, right? I don't write the exam right now, but I can say that this is a good representation of what it would look like for you. The vignettes could be a little longer, so that's something to keep in mind. Sometimes the vignettes are a little bit longer, but typically not as long as NPLEX 2. Those vignettes are like a page, but these could be a couple more sentences. These are relatively shorter vignettes that I chose to start with to make it a little bit easier to get through. Yeah. So who actually read the questions first? Some of you, great. And then the answers? Were you able to answer any questions before looking at the multiple choice? A few of them, yeah, good. Did any vignettes help you at all? Sometimes, yeah. That's pretty accurate representation of what to see. All right, so we're gonna go through, and I tried to include some explanation when needed. So this was our 50-year-old Hispanic woman with hypertension. So question 1, and again, with gender and with both socioeconomic status, race, cultural components, I cannot tell you if it's necessarily appropriate or needed for the cases, but you will see it there. And so that's one of the pieces I just want you to become familiar with, is you're probably going to see Hispanic American, Black American, Caucasian American, or Caucasian, whatever. You'll see these included. And if that's triggering for you, I want you to start seeing it now because they won't change it, unfortunately. We can try to get them to. But there is no clinical real implication typically to these, so a lot of times the gender, but especially to the race and cultural component on these exams. So something that's unfortunate and it's there, but that's why I'm putting it on here because I want you to get used to seeing that. So assume instead she is found to have a serum aldosterone level of 18.4, which is quite elevated. What does the following, does this most indicate? So we have a patient who has essential hypertension. She doesn't want to take blood pressure meds, and she has now have a high aldosterone level. What we're looking at here is primary hyperaldosteronism. So I said when in doubt, look for the kidney. But when we're talking about hyperaldosterone, when we're talking about a high level of aldosterone, that's the only time that secondary hypertension is not going to be a direct kidney cause. So hyperaldosteronism was the answer here. And when we're looking at primary hyperaldosteronism, there is two kind of associations: benign aldosterone secreting tumors or adrenal hyperplasia that can cause it. It counts for about 5 to 15% of hypertension. The initial finding, the classic finding, is high serum aldosterone levels, and the only symptom typically is hypertension. So we haven't come to this pathology yet, but we have talked a little bit about hypertension. And when you're going through this question, you can kind of clinically reason and try to rule out some other causes. If you're looking for the horse, not the zebra, you see high serum aldosterone. This is the only thing that talks about aldosteronism, right? Or aldosterone at all. The NPLEX is not trying to be tricky. So if you have that type of direct association, take it. You know, you're most of the time going to be right. Few of the times you might be wrong, but those few will outweigh the times that you're correct. And there was a few of those on there, right, on this test, where it was the word that was being said or asked about that was then the answer. So trust that gut instinct. And I will post these online. I'll share this with you. So if you want to read through the full explanation, you're more than welcome to. And then I've added some images as well to kind of help support some of your clinical understanding. So we found then her next question was no protein is found in urine. What does that indicate? Is it indicated that she'll have kidney damage? No. Diabetes? Not necessarily, probably not. Testing methods inadequate? That's unlikely. Lack of end organ damage is a positive prognostic sign in hypertension. Yes. No protein in urine. If we did find protein in her urine, then it could be kidney damage. It could be diabetes, right? Microalbuminuria. But since there's no protein in the urine, the only answer that makes sense is D, that she's not seeing end organ damage. So that means it's a good sign in regards to her hypertension. Which statement is true about the renin-angiotensin-aldosterone system? Aldosterone almost entirely determines renin secretion. Renin ultimately originates in the lungs. Angiotensin 2 forms independent from angiotensin 1, where angiotensin ultimately originates in the liver. NPLEX loves doing this. Talks about the kidney, and then throws in something related to the liver, just to confuse you, right? But angiotensin is created, it's synthesized in the liver, and so D is your answer. And if you forgot, we have the liver here, we have angiotensinogen, directly synthesized angiotensin 1, and then angiotensin 2, and then has all these different actions. But they are created from the liver itself. Do they have actions from the kidney? Yes. The one thing that's secreted from the kidney is renin, right? So renin from the kidney, the rest from the liver, right? So that was the big kicker here with this question. I also want you to warn you about things that are always, almost always, or never. Those are often really good detractor answers. So there's a few times that they will be the correct answer, but very rare that an almost or an always or a almost always or a never is the correct answer. And then lastly, the last question here for this one was assume that upon further testing, she was found to have plasma renin that was low. Her aldosterone level is normal. What would the following indicate? And so the idea was to think about, okay, well, what if renin is low, what does renin do, right? If we don't have a lot of, what does renin do when it's secreted? What is renin supposed to help us do in the body? If our kidneys push out renin, what are we trying to do? Keep our, what'd you say? Keep our sodium high for what? Increase pressure, right? It increases, it can help raise blood pressure by holding on to sodium, right? So if renin is low, then we're having some issue with either blood volume, blood pressure, or sodium metabolism. So when we look at the options here, we have salt sensitivity, we have kidney failure, aldosterone secreting tumor, or high intake of renin suppressing vegetable. Well, I'm probably going to rule out D because it sounds a little silly, right? I've never heard directly of a high intake. I mean, there are them, I'm sure, and then we could find them as naturopaths, but this doesn't necessarily seem like a clinically relevant answer to me. So I'm going to get rid of this one. Aldosterone secreting tumor. Aldosterone level was normal, so I'm less likely to choose that answer. Kidney failure. Okay, maybe I could get behind that, but again, aldosterone's normal. I don't know. There's nothing else indicating here that she's in full kidney failure. So that leaves me with salt sensitivity, which makes sense. It's the only thing that relates to renin in those answers. Okay. So that's how I go through these questions. Yeah.
No, you need to stop that. Do you want to be in trouble? Yeah, well.
Oh, whoever's online, we can hear you. Sorry. Welcome from above. Sorry. You could. You absolutely could have low renin if you're in kidney failure. You would also, though, tend to see processes downstream as well with this patient. So you would see potentially an aldosterone mismatch in addition. So since we're only seeing a low renin level, the only thing I can think of is salt sensitivity. Have I heard of salt sensitivity before answering this test myself? No. Okay. Not at all. All right. Salt sensitivity. What is salt sensitivity? Their idea behind salt sensitivity, and this is from the question maker themselves, is that low plasmin renin activity indicates salt sensitivity in the setting of normal aldosterone levels. What does that mean? Well, essentially what they're talking about is someone who, if you are intaking salt, or if you're getting rid of salt, you're having a direct effect on that kidney function. So you could think about someone who's hypertensive, who has a salt sensitivity. You could think about someone who has CHF, has a salt sensitivity. Any condition where sodium is going to directly affect that pathology, you could call a salt sensitivity. Is it a medically diagnostic term? Not that I've heard of in my clinical practice years. Is it on your NPLEX? Potentially, right? So that's why these questions get super frustrating, and you have to just make the connections, the closest connections you can logically to your brain. And that's what I'm trying to do here for you, is be like, okay, in this question writer, what were they thinking, right? Renin, salt, renin, blood pressure, renin, blood volume. That's the only connections I can really make here. Yeah, absolutely. Great question though, Laura, and statement, because no, this is not a medically diagnostic term, nor is it on your NPLEX exam or study guide. Yeah. Yeah, so blood volume, blood pressure, and salt. And then more, right? There's more things that renin can do. So we can see here all the effects downstream of this renin angiotensin aldosterone system, right? So it can affect sympathetic activity. It can affect our sodium chloride, all of that kidney, absorption and secretion process, which we're going to hit probably later this week or next week. Our adrenal glands, so cortisol malfunctions, cortisol issues. Vasoconstriction, so blood volume, blood pressure, like we mentioned, and then even things all the way up to the pituitary gland, because pituitary gland directly affects ADH secretion. So we can see wide mainstream effects from this renin angiotensin aldosterone system. But I would say if you're just thinking renin specifically, think about salt, blood volume, and blood pressure. Yeah. All right, that was our first one. This is our next. So now we have a 24-year-old man with Barrett's esophagus. So he has Barrett's. He also had some asthma. So it's interesting. We're seeing this atopy picture with this person. And he also had some high serum eosinophil levels. So that's curious. So then we get an anatomy question. Which of the structures normally help maintain function of the lower esophageal sphincter and prevent esophageal reflux? So there's this ligament. They talk about the diaphragmatic hiatus. They say the esophagus itself. They say the phrenicoesophageal fat pad. All of those sound really good, right? And the answer is the easiest one, the esophagus. All right? Huh? It can't be that one. It has to be something more complex, right? It is the esophagus. The esophagus takes that J curve right when it is going to hit into that stomach, and it helps actually keep that sphincter nice and tight. The structure of the esophagus itself. So this was a detractor question, trying to get you to choose something that maybe exists or doesn't exist. I mean, these are things, but trying to get you to choose a different answer because the esophagus seems too easy. So when in doubt, don't doubt yourself. If it sounds too easy, it probably is most of the time. Okay. What is the relationship between esophageal problems and asthma? They're likely not related anyway. Well, then why did you ask the question? They're likely both secondary to H. pylori, questionable. They're likely connected through a parasite. Well, we like blaming everything on parasites, but maybe we should hold off. And they're likely connected through the link to food allergies. Well, that sounds good. That makes the most sense to me because I know asthma can have an effect from food allergies, and esophagitis or esophageal issues, what type of esophagitis can be related to food sensitivities or allergies? Eosinophilic esophagitis, absolutely. You guys have been in gastro, right? Yeah, I was with you. So Dr. Saunders, one of her favorite conditions that she sees in clinic when I've been with her is eosinophilic esophagitis. So the answer is D. This one, process of elimination can get you there. And also, if they're going to talk about a parasite, they're probably going to make you name it, right? So they're not just going to give you a grab bag parasite question. They're going to give you the specific name. Which of the following structures is often indistinct or blurred in Barrett's esophagus, and what does it represent? So you have to choose between the Z or the T line, and then you have to choose what is the transition between that line. So the T line's nothing, so it's the Z line. So you had to know that the anatomical structure is the Z line. What is the Z line? It's located right here, okay? So the lower esophageal sphincter, our esophagus with that J curve, you can see that J curve here, and then that Z line separating the esophageal tissue from the gastric tissue. So then if we go up here, it's the transition between the esophagus and the gastric cardia. So if you had no idea if it was Z or T line, you could try to do some process of elimination, right? You could see that, okay, Z or T line's a 50-50 shot. So what about the other answers? Well, I'm looking at middle and lower esophagus or esophagus and gastric cardia. Those are my options. Middle and lower esophagus ideally should be the same tissue. And we know there's some transition point that they're talking about in this question between two different types of tissue. So it doesn't really make sense to have a line between the same type of tissue, right? So I'm probably going to logically say then that I'm going to choose something that has esophagus and stomach because those are two different tissue types. So if I'm doing that, then I have my questions down to B and C, right, between these two. And then you have a 50-50 chance of T line versus Z line. And that's just your best guess if you're not sure. Okay. Now you'll remember Z line forever. Now it probably won't be on your exam, but you'll remember it now. And later on, you'll be like, ah, that's Z line, I know it. All right. Which of the following is an accurate description of the pathology of Barrett's esophagus? Patchy dysplasia, gastric metaplasia, intestinal metaplasia, diffuse dysplasia. So again, we have 4 different descriptor words. We're deciding between dysplasia and metaplasia, and we're trying to find the area. Is it the middle esophagus, the distal esophagus, the gastric cardia, or the entire esophagus? Well, we can do some ruling out here if you're not sure what type of dysplasia or metaplasia you're looking at. Because again, dysplasia, right, is precancerous cells or cells that are replicating at a fast rate. Metaplasia is cells that have already kind of converted over into more of that cancerous state. Again, both abnormal tissue states, correct? So either one seems good, only one's correct, but either one seems good. So if you're looking at location, it's not going to be the entire esophagus. We know that that's typically not Barrett's. The middle esophagus, that seems weird because we know Barrett's is typically caused by that onslaught of either stomach contents or acid or some type of disruption right at that sphincter that causes that change. So distal or gastric cardia sounds good, right? And when we're thinking about Barrett's esophagus, well, it's in the esophagus, so I can probably rule out gastric cardia. So then you have distal esophagus. Then you could literally not know anything else, but you know where it's supposed to be located, and then you could choose B, okay? Again, a lot of this is you're not going to remember or memorize it all. So how can you logically work through, rule out answers that don't make sense to choose the best possible answer given, knowing that salt sensitivity could be there, which is not a great answer at all, right? So sometimes there's not any good answers, but you have to choose the best one. My favorite part about the MCAT, best possible answer. Yes, I took it. It was worse than this. Okay, so which statement is true regarding the eosinophilia and the state of his esophagus? There's no connection, questionable. He suggests he might have eosinophilic esophagitis, which makes the most sense. We've kind of already talked about the fact that there were some food sensitivities or food allergies contributing to them both. So I feel pretty good hanging my hat on eosinophilic esophagitis. If you didn't feel confident about the food allergy question, you might have gotten here, said, oh yeah, of course, it's eosinophilic esophagitis, and then bumped back up and answered that allergy question up above. Totally fine. That's why I read all the questions for a vignette first and their answers available. Then I go back and look at the vignette and kind of try to answer those questions as a chunk before I move on. Do you feel better about this set of questions in the first set? No? Okay. Any questions about these ones that we just went through before I move on? Yep. Yep. Not always, but they're not likely to give away something that simple for you when it comes to microbes or viruses or parasites. They're gonna want to give you a specific name to make you reason through that information. Because if they're trying to test you on as much information as possible and they get one question, the question writer, right? We have to get into the question writer's brain. If they get one question, they're not likely just gonna say parasite, right? They're gonna be like, let me find the exact parasites that I want them to try to pick between, because they're a parasitologist, right? That's probably what they do, is parasites. So thinking about that, it's unlikely that you're gonna get a question where parasite's the answer. Not completely all the time, but unlikely. So if it seems like, and I would say for this one, really the kicker was connecting that asthma piece as well. Now, could asthma have a parasite component that's triggering asthma for you? Potentially. That would be more rare, right? We typically think of asthma as more of an allergic response in the body, and eosinophils can be activated with an allergic response. So that was where they're trying to give you some help, is by connecting the esophagitis and that asthma together as being a combined contributing factor to having eosinophils. But it's tricky, yeah. Over here? Yeah, is that better? Okay, great, awesome. Thank you. Okay. There's our pretty picture. There's that. Okay, moving on. All right. So this is our chronic cough patient. We have some smoking history and diagnosis of chronic bronchitis. So again, they gave you the diagnosis. So then they're asking, what changes can be observed during spirometry of a COPD patient, chronic obstructive pulmonary disease patient? Oh, yikes. We have to know what the heck FEV1 and FVC is. We are going to cover these today when we do respiratory physiology. So we're going to do a review on some of these terms today, so don't fret. But you have two options. You have FEV1 and FVC, and you have to know if it's decreased or increased. So when we think about COPD, we think about what type of a condition is COPD. It's chronic obstructive, right? So it's an obstructive condition. It's going to cause our body actually to have a decrease in FEV1. FEV1 is the amount of air you can force from your lungs in 1 second. So when you breathe out through a little tube, if you've ever done a spirometry before, if you've learned it before, when you breathe out as hard and fast as you can, however much air you can exhale in 1 second is your FEV1. That's going to be reduced in COPD. It's going to be decreased. Now, you're also going to see here, if you look, your FVC also has gone down as well. Spirometry is measuring directly FEV1. It's not directly measuring FVC. That's a calculation that you can obtain from your FEV1. So it's a tricky question. The FEV1 decreased would be the most correct answer. Would this question likely be thrown out if enough people chose decreased FVC instead? Probably. Or they might go both those answers as correct, because in theory, both of them do decrease with COPD. FEV1 is what you're directly measuring via spirometry. Yeah. Forced vital capacity, I believe. Or full vital capacity. I have the acronym later, so that's why I didn't define it for you. Forced vital capacity. Yes. Total amount of air exhaled in your FEV test. So total amount versus the amount forced out through 1 second. So it's a ratio, right? Total amount on the bottom, FEV1 on the top. We measure them both in spirometry. Do you need to know every single one of these terms? Probably not, but I'll give you a helpful chart today that will kind of help you be able to logic your way through these different lung terms. There'll be at least 1 or 2 questions that include them. So it's a helpful chart again. If you can draw it out really fast, it'll at least help you remember the acronyms and be able to define them on the test. That can get you pretty far. So again, surfactant is created by what type of alveolar cells and what's the percentage of complexes protein? This question's awful. So you have to know type 1 or type 2 alveolar cells, which one creates surfactant, and it is type 2. And then you have to guesstimate, or you know, the percent of protein that's in surfactant complex. So it is type 2 and it's 20%. How would I know that? I would have probably taken an educated guess. I would know type 2 cells produce surfactant because type 2 cells, they are the defenders of your alveoli. They're actually your immune system cells. They keep the space free from fluid, and they can help actually repopulate the epithelium after some type of injury. So type 2 alveolar cells are the ones that secrete surfactant. The 20 to 50%, that's just me guesstimating. I mean, this is the correct answer, so we know. But if I was answering this question as you, it'd be, okay, well, the thinking about surfactant complex as a whole, how much of it could be protein? Unlikely that 50% or more is full protein on surfactant, given it's like a very thin, syrupy, like liquid. So logically, it's not very structural, it's not very strong, so I'm gonna say less. And that's how I would go through and logic myself through this question. Can you find these numbers? Absolutely. Should you memorize these percentages? Never. That's a waste of your time. Okay. The big question here is, can you figure out type 1 versus type 2? And then the question maker was probably just being very excited about their surfactant knowledge. All right. Okay, this is good. What level of the respiratory tract is affected in chronic bronchitis and emphysema, respectively? So we have chronic bronchitis and we have emphysema. So chronic bronchitis, we're thinking, okay, where in the lung tree is chronic bronchitis going to affect us? And then emphysema, where is that going to affect us? Well, if you know one, you can rule some things in and out. So I like to start with bronchitis because I think you can logically think through bronchitis a little easier. Bronchitis, you have that chronic cough, you might have some rales or rhonchi, typically not bacterial in nature, it doesn't need antibiotics. So it's not all the way down in your alveoli. So you can rule out these 2 answers right away. So then is it all the way up in your trachea or is it in your terminal airways? Well, if I'm getting this kind of chronic cough with rales, it's probably going to be further down in my lungs. So terminal airways sounds good to me, even if I'm not sure what that means. Then I see alveoli as my only option for emphysema. Great. If you know emphysema affects the alveoli, you could start there saying, okay, I have these 2 options of either terminal airway or trachea. I know chronic bronchitis isn't just affecting my trachea. So then you could rule out that answer. So that's how I would logically go through those if you forget the pathogenesis. If you have no idea what those even processes are, trachea's here, we go to our bronchi, then our bronchioles, then our terminal bronchioles right before we go to our alveolar sacs. Okay. And again, if you want to histologically look at it, these are the histological differences, and these will be posted, these answer keys. You'll have access to these images, and you can see the differences in your type 1 and type 2 cells. Which of the following is not a cause of fungal pneumonia? Well, the only non-fungus, Streptococcus pneumoniae. It's a bacterial cause of pneumonia. That's how you get that answer. Strep is bacteria. They give you a strep or staph, it's a bacteria. We'll do some micro to help you do a dichotomous key to help you quickly be able to suss out coag positive, coag negative, gram positive, gram negative, all those terrifying things that you memorized once for an exam. But Streptococcus pneumoniae causes a bacterial pneumonia, not fungal. Yes? Yeah. Yeah. Yes. Yes. It's going to be presented as a pathological condition. It's going to be categorized under COPD. So you'll get COPD with chronic bronchitis and emphysema. And the big key of the puzzle here is to be able to tell the differences between their pathogenesis, so where they're actually located in the body, and potentially risk factors and how the patient would clinically present. That's really where you're going to hit it in NPLEX the most. They're not going to get too much in the minutia of condition, pathological change, syndrome, etc. But they will want you to know the differences in like physiological changes to the body in emphysema versus a chronic bronchitis versus like a pneumonia. Yeah, does that help? Yeah. The most of the time when I see emphysema brought up, it's either in a question like this, where it's like trying to figure out where exactly is it affecting in the tissue, so alveolar tissue specifically, or the presentation of a patient, clinical presentation in a greater picture where they're talking maybe about someone who's more of like a pink puffer, blue bloater, like that typical clinical presentation that you'd see, pink puffer being more like an emphysema patient. And then they might ask some questions about complications. So like lung scarring, increased risk for potentially pneumonia, or risk factors like smoking leading to cancers. That's when I tend to see these brought up the most. Yeah. COPD is a good grab bag question though for NPLEX, so it'll probably be on there in some way, shape, or form. Yeah. A lot of times they like to combine those, like we saw with the FEV1, FVC, like all those things, because it's really easy because you're doing spirometry. You also might see that with asthma. So that would be the other time you might see those different functional vital capacities. All right, now we move on to another person with hypertension, but this time this person presents with paralysis of arms and legs, metabolic alkalosis, hypercapnia, and myoglobinuria. Interesting things. Should be taking some herbal supplements. Great. Every patient of mine, what are you taking now? She recovered fully with elimination of the herbs and the administration of spironolactone. Interesting. So anyways, then we get a question talking about glycyrrhiza, and it inhibits this specific enzyme, 11-beta hydroxysteroid dehydrogenase type 2, in the kidneys. Okay, that might be helpful. And how does inhibiting this enzyme explain adverse effects experienced by the patient? Adverse effects meaning paralysis, metabolic alkalosis, hypercapnia, and myoglobinuria. Okay? So let me get our answers. So we have cortisol not being activated, aldosterone being inhibited, and aldosterone being activated, or cortisol not being converted to inactive cortisone. Now it is D, that's the answer, and I do have, we'll reverse here in a minute, but cortisol, cortisone, and then that's where those enzymes are, is between the process, the conversion of cortisol to cortisone. So if you know that, great. I don't know a lot of people that would just magically know that in your brain right now, but if you do, awesome, then great, then you knew the answer. If not, how could we logically walk our way through this problem? So first you need to identify, is this a cortisol or an aldosterone problem? So what could be some hints that could tell us it's cortisol versus aldosterone? Anything, throw it out there. Location? Why? What gives you some hints with the location? Okay, awesome. I love that. Yep, kidney, adrenals, that sounds great. Perfect. Aldosterone's also in those collecting ducts though, right? But it affects the collecting ducts. But yes, adrenals, kidney, cortisol. I agree. I like that. What are some other associations that might lead us down the pathway to help us suss out cortisol versus aldosterone? Improves the spironolactone. So what does spironolactone do? We don't know. We're not in pharm, right? We're not sure what spironolactone does yet. That's fine. Improves the spironolactone. We know spironolactone does something. Yeah, exactly. Spironolactone has something to do with the adrenal system. So I'm going to lean towards adrenal system. I like that logic. Well, do we know anything about glycyrrhiza yet? We technically don't. Cortisol, yeah. You hear steroid, and so you're like, okay, so there's it's a hydroxysteroid, so maybe I'm going to lean towards cortisol. I like it. All these things make sense. Glycyrrhiza also typically affects kind of that cortisol process. So if you know true licorice, not DGL, but true licorice can affect blood pressure and it can also affect your cortisol levels. So if you knew those things, this would be helpful, but you don't know that technically yet, right? Because we don't know anything about treatments and the NPLEX 1. You actually might know, right? Some of you have graduated or some of you have prior herbal and farm knowledge. You might actually know that, which could help you, but technically you should be able to answer this question without it, without that knowledge. So we have an idea that it might be cortisol. So then we're saying, okay, is cortisol not being activated and it's causing excessive glucocorticoid receptor activation? Or is cortisol not being converted to inactive cortisone? Thus, it's free to activate non-specific mineralocorticoid receptors. So essentially, these questions are asking two different things. Either cortisol is not activated, and then it's causing excessive steroid receptor activation. It kind of doesn't make sense to me, right? If something's not being activated, how is it activating something else, right? I mean, maybe, but that makes less logical sense than cortisol is not being converted to cortisone, which is its inactive form. Therefore, it's doing a lot of stuff, right? And so if I know nothing about the process of this enzyme and I can identify that cortisol is going to be my problem child, then I'm probably going to go to D because it makes logical sense. It's not being inactivated, so it's activating more things, right? And so that's how I'd logic my way through this question if I had no idea what I was looking at. Now, obviously, if you chose aldosterone, you'd be pushed down kind of the wrong pathway, the wrong side. Some other things that you could think about, because initially you might want to go down that pathway because you're hearing things like metabolic alkalosis. You're like, okay, so maybe there's something with our metabolism system, so then maybe I do think about the kidney, right? Hypercapnia, that's just going to be your treatment for metabolic alkalosis. So that doesn't necessarily help me. Myoglobinuria, you're going to see more myoglobin actually in your urine. So that doesn't necessarily help me a ton trying to decide between aldosterone and cortisol. So really, if you didn't know the exact place of this enzyme, my process of elimination would be exactly what you just said. Locations of things that you talked about. Do I hear the word steroid that makes me think cortisol? And then which question answer makes the most logical sense? Yes? Yes, you're not wrong, no. So aldosterone is inhibited from being deactivated, so it's not being deactivated, it's being stopped from being deactivated, and thus overly activating mineralocorticoid receptors. Aldosterone is being activated excessively, so instead of being not inhibited, it's being activated a lot, and thus overly activating non-specific mineralocorticoid receptors, essentially saying the same thing. Yes? Totally. What threw you? Yeah, I would say trust your gut, right? So your gut gave you good information initially. So that's great. That's why we do these tests, right? If your initial gut option was to cross those off and you didn't trust it, trust your gut next time. If your initial option sent you down the wrong pathway, don't trust your gut. Maybe rethink it later, right? That's why we're doing these tests to see, are you a first pass answer or are you a second pass through answer person? Okay, so this is the process here of cortisol conversion. I do have to say there are a lot of HPA, HPO axis questions. So understanding this process of cortisol down through aldosterone, down through cortisone, and over to testosterone and estradiol, this wouldn't be a bad pathway just to become familiar with. Not only will it help you on this test, but it'll probably help you in the future as an ND. So this one is not a bad one to at least commit to somewhat memory. I've never seen this enzyme tested again. So I think that's a one-off, but you never know. They'll throw those off on there. All right. Why does this patient have hypercapnia? This is just your respiratory response to compensate for metabolic alkalosis. This is understanding what metabolic alkalosis is. And you're trying to increase, you have hypercapnia to respond to it. So this is understanding a little bit of your metabolic processes. There are some additional kind of detractors here, but overall, this is the most obvious answer. I'm gonna move on from that one. What are the following clinical problems? Oops. Which of the following clinical problems would you have expected to find in this patient giving her problem? Super great. So are we dealing with hypernatremia, so high sodium, high potassium, or low sodium? And then are we dealing with alkaline phos or creatinine phos? So this question, if you can identify what ion is going to be your problem, you can answer the question. So if you know that you're dealing with hypokalemia due to pseudo hyperaldosteronism, from having this inadequate activation, you would already know, right? You'd already know that. You probably don't know those things. So then I go back up to what is happening here? What is happening here, right? She has metabolic alkalosis. What's metabolic alkalosis? Great, too much bicarb. And the opposite of metabolic acidosis, right? Our blood's not too acidic, it's too basic. Yeah, great. So then what's hypercapnia? Okay, due to? Right, great. She's paralyzed, her arms and legs aren't moving, that's fun. And then myoglobinuria, what's that? What's myoglobin? Sorry? We're not sure, that's fine too. Myoglobin, yes, absolutely, muscle breakdown in the urine. So let's look at myoglobin here. I'll show you a little picture. I didn't have my picture of myoglobin on here, so we'll pull it up. Hemoglobin and myoglobin. Remember, hemoglobin binds the heme. Myoglobin is that globular protein. We can see here that when we have myoglobin.
If you're an Oregon homeowner 2022.
Oh, calm down. Oh, I'm going to have to play her. Okay, I'll just put a picture in here for you because that'll be easier. But myoglobin, when you have excess myoglobin in your urine, you're having blood cell and muscle cell breakdown. Okay, so blood and muscle breakdown is happening. So you're seeing myoglobin in the urine. So when we're looking at all those things, you may not still know hypokalemia is going to be your problem. You might not necessarily know if it's going to be alk phos or creatinine phos. When I go through here, when I'm logically walking through this, alk phos is not really richly found in skeletal muscle. So I am going to eliminate all answers that have alkaline phosphatase because I'm knowing it's muscle breakdown. Alk phos I typically associate more with bone health. And so I'm going to remove alkaline phos from my answers, and I just have my creatinine phosphokinase. Then I'm dealing with, is there too much potassium or too little potassium? Potassium wasting, a way that you could figure this out is if you knew what spironolactone does. Spironolactone is a potassium sparing drug, so it holds on to potassium. So if I'm giving someone a potassium sparing drug to hold on to potassium to treat them, then I'm assuming their potassium was low to start with. You might not know that. If you knew the pharmacology, it would help you in this question, which sucks because it's NPLEX 1, right? And so again, to your point, Laura, there's a lot of these kind of tricky things thrown in here that if you have any prior knowledge of herbs or farms sometimes, it will help you on this test. That's why some of our students who take it later on in their days actually do have a little bit of an advantage because they'll throw in some of these clinical pearls that wouldn't necessarily be pertinent to NPLEX 1. So if you're taking it later on in the game, good for you. You might have a leg up. Another option here that you could have used if you weren't sure, if you maybe were still unsure about these two, you go to question 18 and say, what are additional treatments suggested by this pathophys? And see you have potassium, sodium, magnesium, and calcium options. It's not it's not a super common thing that we give people calcium as a treatment, especially for something that's adrenal in nature. Sodium maybe, right? If we had like adrenal insufficiency, true adrenal insufficiency, but we're thinking that cortisol is in excess. It's not being inactivated. So it doesn't necessarily make sense to give someone salt. So then I would go to the opposite of sodium. Sodium versus potassium. If I'm not giving sodium, I'm probably going to choose potassium as my option. Magnesium is given less likely for things of this nature. If I was going to choose magnesium, it'd be for something like the heart, right? Then I would think maybe magnesium, like decreasing blood pressure, vasodilation, something like that. And then this question here is an anatomy question. What part of the adrenal gland produces aldosterone? So this is getting back to knowing these tissue types. So we have our zonas here, glomerulosa, fasciculata, reticularis, and our adrenal medulla. Our glomerulosa is the production of our mineralocorticoids that produces aldosterone. Aldosterone here. Zona fasciculata gets our glucocorticoids. That's where our cortisol is produced. Zona reticularis produces our androgens, and then our medulla produces epi and norepinephrine. Okay. All right, now our migraine person, migraines and sulfites. So we find our patient with migraines, sulfites in our diet are triggering our headaches. What enzyme is responsible for the metabolism of sulfites to sulfates? So this is one where the most obvious answer was the right answer. The only thing that said sulfite on it, oxidase, is the correct answer here. Sulfate hydroxylase doesn't exist. So that was a detractor there. It's not real. So if you chose that, that would be a great option because you chose the other thing that said sulfate or sulfite, but it unfortunately doesn't exist. So sulfite oxidase is your answer here. Cytochrome C is again in the electron transport chain. Alcohol dehydrogenase is involved in our catabolism of ethanol. So if you knew those two, if you recognize those two words as being processes in other metabolic pathways, you could probably eliminate them and you'd have a 50-50 shot at sulfate oxidase versus hydroxylase. If you're thinking about something that changes a sulfite to a sulfate, you would really need to know biochem, I guess, for oxidase versus hydroxylase to help you. So I think the best bet here is you're gonna, if you don't know this one, you're gonna get yourself to a 50-50 shot, unless if you really know your biochem enzyme names, like oxidase, hydroxylase, reductase, dehydrogenase. If you're good with biochem, that wouldn't be a bad thing to memorize those, what they mean, what they do. If biochem's not your forte, don't waste your time there. I'll give you a biochem sheet that is kind of your bread and butter that I would focus your attention on. I'm going to try to hit that today if we have time. This is that pathway if you're curious to know. So it is a part of your methionine to homocysteine pathway, your transmethylation pathway. And you get down here and you have your sulfite to eventually your sulfate. You also can get some pyruvate off of here. Who would have known? Not me. Okay, not me, and I teach biochem. Okay, what part of the body does each supraorbital nerve innervate? So we get some anatomy here. The answer to this one is half the forehead. And we can see here our supraorbital nerve. It's going to come right down here, a branch of the facial nerve, and it's going to nervate half of our forehead here. This also shows a couple different other nerves and their dermatomal patterns, just if you wanted to know, if you're interested. But supraorbital nerve, branch of the facial nerve, it's going to innervate half of the forehead. I'm going to pop down to here because this says of which nerve is the supraorbital nerve a branch, and it's a branch of the frontal nerve. So identifying here, what is the supraorbital nerve doing? If it's innervating half the forehead, and it is doing some touch. Yeah, compression of that nerve can relieve some headaches, can also cause some movement of the face. So when we think about what does the frontal nerve do? What's our frontal nerve main action? Has some sensory action, great. And does it do some movement? Yeah, eyebrows, yeah. So frontal nerve branch leads down to that supraorbital branch as well. Similar action, which makes sense. Mandibular nerve, that doesn't make as much sense down lower here. Trochlear nerve, we know that one's over involved in hearing and vestibular and balance. And then not a branch becoming main nerve from the brainstem, we know that's not true. There's very few things that come directly from the brainstem, and I've never heard of supraorbital nerve coming from the brainstem. So frontal nerve is where we end. All right, going back up here, which of these cofactors does sulfate oxidase require? Again, if you didn't know what sulfate oxidase was, you're like, wait, I just answered this question here, and I put sulfate hydroxylase. Now they're asking me about sulfate oxidase. I'm going to change my answer. Okay? So if you had no idea, they literally gave it to you 2 questions later. I've seen this on the NPLEX, so trust it if they do that for you. And then you have to decide what the cofactor is. Of these, molybdenum's the most obvious. Selenium can be used as a cofactor, but vanadium and radium I have not seen used as cofactors in many enzymatic reactions. Magnesium is more common. B12, all your B vitamins are really common. Niacin. not so much radium and vanadium. So I could rule those two out. And then I'm thinking, is it selenium or molybdenum? Selenium, I mean, you would really just have to kind of understand where these could be used as cofactors into the body. But molybdenum is very specific. They also then give you a hint on the next question with what other human enzymes require the same cofactor, and they give you two other enzymes here. Your giveaways could be, this is the only other one that has an oxidase. So if you chose sulfite oxidase, these are peroxidases, so that's different. So that could be a giveaway if you weren't sure. Glutathione peroxidase and deiodinases are selenium-dependent enzymes, and then the others are iron-dependent. So if you weren't sure, these would be probably your process of elimination. I'd go to what one looks the most like the enzyme I was trying to identify before. No other enzymes use the same cofactor. This could sometimes be used. When they give these answers, though, I've often seen them not being the correct answer. Most of the time, I want you to choose the right one. Not saying it's an always, but. All right, leg pain. Which statement best describes the acetabular labrum? Is it gelatinous gel, a projected lip-like ridge, a ring of fibrocartilage attached to the bony rim of the acetabulum? Three-sided ridge of fibrocartilage connective tissue that makes up the labrum. It's avascular, stabilizes that hip joint. If you didn't know what that was, that's okay. This would be some anatomy review for you. But again, if we're looking at what that labrum is, you can see here, that acetabulum labrum, I know it's small, but it's occurring right around here, that ring of fibrocartilage, right alongside here. Why do some people get a labral tear when others do not from the same trauma? This one here, I don't love this question for many reasons, but it is what it is. So all of them are the correct answer. I would be shocked if this type of a question ended up on your test, but it's been there before clearly, so it could. If you get a question like this and two of the answers seem right, you can't rule them out, I would choose all of the above. That's kind of how I would go with these type of questions. And then this is the question that would be likely thrown out because this is a question about diagnostics. But I did, just for people who are curious, I did include the test here. But I doubt this would be included on an NPLEX one. Yeah. Yeah. Absolutely. And that's completely appropriate. You still need to answer it, right? Because they might not throw it out. So your best case is to go through and try to identify what is the most likely association with what we were talking about, right? Acetabulum labrum. So I'm going to go down to thinking about something that we were already kind of discussing. We were not really talking about hip infections. We're not talking detect all hip problems. That's one of those all questions. Probably not that. Hip osteoarthritis, that doesn't really help me here. So labral tear is the only thing that makes sense based on what we were discussing previously. But again, this would probably be a throwing out question just based off of its appropriateness for NPLEX 1. When we get here, we have a patient with stage 3 breast cancer. It's spread to several regional lymph nodes. She had a lump removed. And then they get this question of the mutation of which of the following genes can lead to breast cancer-related changes in epigenetic methylation. What is the one gene that talks about methylation? That is your answer. Methylene tetrahydrofolate reductase, the MTHFR gene. Okay, most of your genetic questions are relatively straightforward like this. You might see a BRCA1 or BRCA2 question. You might see an MTHFR question. Maybe with some celiac disease, might you see a gene association question. Most of the time, though, it is a pretty straightforward, like this is the only answer that makes sense to me. I haven't seen a lot of, every once in a while there is, but I haven't seen a lot of minutia when it comes to genetic mutation questions. So MTHFR is going to be your answer here, the only one that makes sense. What tissue in the breast does most breast cancer arise from? This is knowing some pathophys, some pathogenesis of breast cancer. So I do have breast cancer progression here. We have our normal duct, we have our epithelial atypica, our ductal carcinoma in situ, and our invasive ductal carcinoma. So this is going to be the most common progression of breast cancer. So ductal epithelium is going to be your most common breast cancer tissue that it arises from. Not the only, not necessarily the most invasive, but the most common, which is what they're asking. You also could see here skeletal myocytes, connective tissues, skin stem cells. None of those really make sense if you know anything about breast tissue. So even if you weren't sure if this was the correct answer, you could probably rule these out. What lymph nodes drain the right breast? The ones that are closest, the right axillary. I loved this question. I was like, oh yeah, got it. This is a question you could easily talk yourself out of the correct answer though, because it seems too simple. It is not. It is directly your right axillary nodes. Another way that this could be discussed is with like elephantitis or lymph node swelling. A patient had a procedure or a lumpectomy, and they're now presenting with elephantitis. Which lymph pathway or lymph nodes are most likely the cause? Your right axillary lymph nodes would be your answer there, because that's the major drainer of breast tissue. Oftentimes after some surgical removal of a lymph node or after a breast tissue lumpectomy, you can actually see then inadequate lymph flow and then elephantitis or swelling on that arm. Absolutely. Absolutely. When in doubt with anatomy questions, please use your body to help you. I was doing all kinds of crazy movements in NPLEX 1, especially on the MSK stuff, to remember actions and innervations and motions and muscles. No one, I mean, they might look at you funny, but who cares? You'll pass the test, and too bad for them. All right. What statement's the correct statement about epidemiology of breast cancer? Second most common non-skin cancer, or the most common non-skin cancer, the least common non-skin cancer, or we don't know. Okay, well, we know it's not, we don't know. We know it's not the least common. So is it the most or the second most? And it is the most. Now again, remember this is 2 to 3 years old information. So something to keep in mind, if there was something that just came out, like a study that came out right before the NPLEX, it's not going to be updated yet. It's going to be at least a year old. That's when they're writing the questions. There's at least like 1 or 2 epidemiology questions. They tend to be pretty straightforward like this. We'll come up with one here in a moment. So how common is prostate cancer in general compared to aggressive prostate cancer that metastasizes? So prostate cancer is common. So we know it's either B or C. And then aggressive prostate cancer, is it uncommon or is it making up more than 50% of the cases? If you think about the pathogenesis of prostate cancer, many men develop it late in life, and many times it doesn't progress past being local. It doesn't metastasize. So if you think about that pathogenesis of prostate cancer, B makes the most sense. It's going to be common, but it's not going to be likely to become aggressive. It can, but it's less likely, right? And that's what the question's asking. Which one's the most correct answer? Now we get some anatomy questions. My boards one was like all about male reproductive anatomy. I think I had like 20 or 25 questions about male reproductive anatomy. It was not my favorite. No offense to the guys out here, but I did not spend the adequate amount of time to know the minutia of male reproductive everything compared to female and everything else. But that's just sometimes how the cookie crumbles, and I still passed. I definitely guessed a lot on those sections. But we have compromise of which of the following structures during prostatectomy is likely with what resulting problem, okay? So when we have prostatectomy, so we have removal of the prostate, what is likely to be affected, and then what's likely the result? So that's what we're asking about. So none of the above, okay, that's an option. Or is it going to be the prostatic artery, the internal urinary sphincter, or the levator ani? So a muscle, a sphincter, or an artery, that's what we're asking for. Is it going to deal with hemorrhage, urinary continence, and chronic prostatitis? when I think about this question, if I don't know anything about these structures, and this is your sphincter that it ends up being the answer, if you want to know. But if I'm thinking about these answers here and I'm not sure, I'm going to think about, well, prostatectomy has to be a relatively safe procedure because people have it happen. And I'm not hearing about a bunch of people dying from hemorrhage, so I might get rid of this answer because I'm not hearing about a bunch of men bleeding out from their prostatectomy. Not saying it couldn't happen, but less likely. Now, the prostatic artery is affected, actually, but it doesn't tend to lead to hemorrhage. It tends to be completely benign. It doesn't cause any long-term pathology for patients who have this happen. So then I'm left with chronic prostatitis or urinary incontinence, which I know are both relatively common side effects after prostatectomy. So then do I think a muscle is being affected or a sphincter? If I'm going to guess, I'm going to guess a sphincter because that sounds like something that would be much more close to a prostate. I feel like during a surgery, it's less likely we're going to destroy a full muscle, right? So that's how I would logic my way through this question if I had no idea. If you look, though, where the internal urethral sphincter is, it's right by where that prostate tissue is. It's very easily nicked or cut or loosened or stretched during this procedure, which then leads to urinary incontinence and urinary frequency. So that's the pathogenesis behind the why. But even if I didn't know, and this is even a female, this isn't a male, that's why there's no prostate. But if I didn't know, that's kind of where I would go. And then how would prostate cancer spread to the seminal vesicle? So understanding that the prostate and the seminal vesicle are relatively close structures or close together, you then can think about, okay, would it need to spread via blood, direct extension, lymph, or the biopsy? I'm probably going to decrease my hat on iatrogenic, so I'm going to take off D. I don't think it, I think because it's a local structure, I'm probably going to do direct extension, which just means it's going to spread over from one tissue structure to the next. Blood, if I was trying to get from one system to another, I might choose blood or lymph, probably lymph over blood. But direct extension, given they're both in the same region, that would be my best guess, which is the best answer. Yeah. Yep. I never have read the case for this question, this problem yet. So I read all the questions first and their answers, tried to answer them first, and then went back to the case to make sure I wasn't missing anything. That's what I would suggest doing. Yeah, absolutely. And that's part of the tricky part of the test. That's why I encourage you, the more practice questions and practice tests and scenarios you put yourself in, the better you'll get at being able to kind of suss out some of these purposeful tricks and sometimes when they're helping you. And know that you're going to have a question that's going to pull you off the wrong way, and that's okay. Yeah. And then why is he having hot flashes? Loss of his prostate, therefore reduced testosterone. Reduced testosterone affects secondary to degrelix, so like what the heck? Due to a paraneoplastic syndrome from prostate cancer or normal result of male aging. Well, typically normal result of male aging doesn't lead to hot flashes. So then at this point, that's when I would look up here at the top because they mentioned a word that I hadn't seen before, which is degrelix. So I'd say, okay, what else can I find here from this male? So I see that he had prostate cancer, it's spread, he had some lymph nodes involved, he's taking this med, which is an androgen receptor blocker. Interesting. And he's having hot flashes. No other symptoms, the cancer was detected by blah, blah, blah. So then I go back down, I'm like, okay, well, it's an androgen blocker. So that makes the most sense then to me. If it's androgen blocker, it's blocking his testosterone. So that's probably why he's having hot flashes. It told me it in the vignette. Would this be an appropriate answer? I mean, this makes sense to me, but you still could have appropriate testosterone secretion without a prostate, right? This doesn't completely answer the question to me. We know that one's wrong, and then this is unlikely. There's nothing pointing to saying he has a paraneoplastic syndrome in this case. All right, a skin case. Again, you don't need to look at the vignette for this. You can just say here that what is the correct order of epidermis layers, starting with the outermost going in. So starting from the needle going inward. That's what I always tell people, outermost in. So you can see here we have corneum, we have granulosum, spinosum, and basale. So you just have to memorize that, come up with some type of acronym for yourself. Does anyone have a good acronym to remember this one? CGSB? Perfect. I love it. That's great. Come up with your best acronym. My undergrad students have a lot more maybe inappropriate ones. I don't know. Or maybe appropriate. It's a religious school, so I don't know. Depends on the day for them, I assume. Anyways, but CGSB, figure out what your acronym is going to be and stick it to your memory. This is on here relatively often or in some way, shape, or form. So keeping in mind kind of these different layers and what's going on with them for the skin. If there's an integumentary question, that will help. They love talking about bacteria for the skin stuff. So which of the following correctly describes Staph aureus, a common cause of skin infection? Is it motile? Is it spore forming? Is it coag positive? Is it gram negative? I have a helpful thing that I teach micro and we do a micro knowns case. So I literally am growing bacteria right now in my lab for that. So I'm playing with these all the time and experimenting and hopefully not creating the next super virus or bacteria. But Staph is a gram positive. Staph and strep are your big gram positives. Staph is coag positive, strep is coag negative. So those are great kind of start to your dichotomous key to start separating and parsing them out. Dichotomous key is kind of like your roadmap to identify an unknown bacteria. It can be really helpful for studying because it puts things in categories. So I think next week we'll be making a dichotomous key together to kind of help us try to categorize these bacteria in a way that makes sense. All right. We won't be able to get all of them, but we'll try to get the major players. But so here, you're then left with, is it motile, spore forming, or coag positive? If you don't know those things, you probably could get that it's a gram positive bacteria because you've heard of that. So is it motile? We're not sure. Is it spore forming? Spore forming, think of like your anthrax, your bacillus, those the things that could live for a long time, that could be mailed, that could be bioterrorism weapons. Staph is not that. And then again, non-motile versus motile, you kind of just have to know. So I think a dichotomous key will be the most helpful thing for you there, but it's non-motile bacteria. Coag positive is your answer. And this is my little, quick and dirty guide to Staph versus strep. Obviously, there's many more species here than just aureus and pyogenes. Both gram positive, catalase and coagulase positive, catalase and coagulase negative. Essentially, catalase is you put hydrogen peroxide on the bacteria, and if it bubbles, that's the test. It's very scientific. Coagulase, you put essentially some blood in there, and if it coagulates, it's positive. So that's what those tests mean. Both of them are beta hemolytic, which we'll talk about, and there's multiple strains. Okay, acute infection, immunology. Which inflammatory cell is the most prominent during the initial 24 hours of an acute inflammation caused by an infection? Your first inflammatory cell that's going to come to the game that's on this list would be neutrophils. Okay, now there are some other options here, right? What are some other things that show up to the game early for the immune system? Sorry? Macrophages, yeah, macrophages would come up relatively quick. They're not quite as fast, but they come in pretty soon to start mopping things up. And they will hold the little antigen on their body as a signaler. Yeah. Yes and no. But we can then look up at this case and say, okay, is there any hints telling us, what's going on here? It says that they started a course of antibiotics yesterday, so we could assume that we're thinking maybe something bacterial in this nature. But neutrophils typically are going to come to the game regardless pretty fast. So neutrophils now, yes, lymphocytes will show up more in viral infections, absolutely, and so it'll be a higher amount. But neutrophils are still going to be present and come in pretty quick to the game, but they might not have much of a job if it's not bacterial. Yeah, good. Eosinophils are slower. If you don't like immunology and you want an easy way to learn it, Cells at Work. It's a great little anime Netflix series that you can watch. They're like 30-minute videos. And they go through kind of all your major players. It's written by med students. It's a great non-brainless way to study immunology. Cells at Work. Which of the following does not affect the likelihood to develop a keloid scar? Age, genetics, skin pigmentation, or gender? This one, they say that although there's a higher incidence of women that have keloids, they affect men and women equally. So gender is the answer. It's not going to change the likelihood of developing a scar. Age can, genetics can, skin pigmentation or even skin type or texture can, but gender, it can occur equally. All right, we're almost there and then we're gonna take a break. Now we got UTIs, urinary. Which statement is true regarding normal urination? So we have a couple different things. We're talking about the detrusor muscle. Is the detrusor skeletal or smooth muscle? That's our first question. So is the detrusor muscle skeletal or smooth? Answer smooth. It's a smooth muscle. And then, so now we know it's a smooth muscle. We're saying, is it inhibited by parasympathetic activity and contracts due to beta adrenergic activity? Or is it inhibited by the opposite? So which one inhibits urination? Does sympathetic or parasympathetic activity inhibit urination? When you're running from a bear, are you urinating? Probably not, right? You might, like, because of nervousness, you might actually, like, wet yourself a little bit, but your body is not in that relaxed state to relax those smooth muscles. When you're running from a bear, taking the NPLEX, you might have some nervous pee, but you're not actually releasing your pee without your control, right? So when it comes to sympathetic beta receptor control, beta essentially input is going to decrease urination. So then we can see here that it's inhibited by beta adrenergic activity. It's going to contract during parasympathetic activity when we're able to relax. So we can finally go pee and have a bowel movement and all that good stuff. All right. What pH would your urine be knowing this organism is present? Well, it's like, okay, well, what organism? Then I have to read the case for this question, right? So she has burning, frequency, urgency, gross hematuria, yada, yada, yada. Proteus mirabilis. What is something specific about that bacteria? What does it do? Good, great, you'll learn right now. Basic P. If you have basic P, non-acidic P, think Proteus mirabilis. When in doubt, give me your pathognomonic for Proteus, basic P. So your pH is high, above 7, more basic, think Proteus. So this is because it splits urea, so it leads to more alkaline urine. That's what it does. I've seen this often in the opposite direction. So patient had, on a dip, you see a pH of greater than 7. She's had recurrent UTIs that haven't responded to antibiotics. What's the likely organism? Proteus would be your organism. And then they'll list like E. coli, Proteus, Pseudomonas, and strep something. And then Pseudomonas would be your answer. They are Proteus, sorry, Proteus would be your answer. Trying to confuse you all. All right, which of the following most likely accounts for her recurrent UTIs? I mean, you could just say probably the wrong antibiotic, but allergy to nightshade vegetables. There's nothing in her case that told me she has an allergy to nightshade, so I'm going to get rid of that one. Antibiotic-induced dysbiosis. Okay, maybe she's been on multiple rounds. Underlying immunodeficiency. Again, is there anything in her history that tells me she has underlying immunodeficiency? No. That could be an answer if there's something that gave me that hint, though, right? But there's nothing in this case vignette that says she has some underlying immunodeficiency, so I can't guess it's there. That'd be like me walking up to a patient and be like, oh, you're sick like 5 times out of the year, you probably have HIV. That's not appropriate medicine, right? So like, yes, that's an immunodeficient condition. Yes, that could cause someone to get sick multiple times. That is a correlation, not a causation. We can't make that on the NPLEX either. And then congenital malformation of her bladder, I mean, possibly too, but I have nothing that's giving me that indication in her history. The only thing in her history that gives me a cause is that she's had 3 UTIs and they've all been treated by antibiotics. That's the only thing that makes sense with this question based off of this vignette. Now, could we change this vignette slightly? She is a 3-year-old kid and has recurrent UTIs that aren't being treated by antibiotics appropriately. Then I might think congenital malformation. She has a history of immunocompromise, or she has a history of treatment for cancer. She's been on chemotherapy. She's been in remission for 6 months. Then maybe I think of immunocompromise, right? They would have to give you something in the history to send you down that pathway. So don't be detracted because they all could seem like good answers. Does that help at all? Kind of logic your way through? Yeah. Half the battle is just being able to talk yourself into an answer on this test. or out of an answer sometimes. Okay. What's the reason for this organism's effect on urine pH? So I already mentioned it, but it produces urease, which creates ammonia from urea. So if you know that this organism causes basic pH, so if you've memorized that now and you know that, you could look at this and be like, okay, well, I'm not sure about this one, but I know that it's not going to acidify everything because I know it's basic. If it's generating excessive oxygen, that's probably going to make things more acidic. And I don't know that there's any like urothelial surface markers that are being triggered here. So I'm probably going to go for the one thing that's a base here, which is ammonia. That's what I would justify if you didn't know. Choose the base instead of the acid. But that is what Proteus does. It causes urease, which creates ammonia from urea. Yeah? A respiratory burst or stimulate a strong immune reaction? This one seems a little aggressive. No, probably. I'm sure, yes. Generates excessive oxygen, probably. Like a reactive oxygen species, possibly. So maybe. I don't know off the top of my head, but I can say for this one in particular, this would be the answer I would choose. Yeah, I mean, could it happen in theory? I feel like this one's a little aggressive, so probably not, but possibly, right? I don't know what every single bacterium does exactly to the body, but what I'm thinking about here is what is the one thing that could cause a base? And that's the only question that talks about a base at all, is ammonia. Okay. And then what describes Proteus, right? You're like, oh gosh. Okay, so it is gram-negative. So again, this is where our dichotomous key will help us a lot. It's gram-negative. It's a facultative anaerobe, so it can be used with oxygen or without. So it doesn't need oxygen to survive. It's in normal colon flora, and it's motile. But if we're thinking about, okay, well, this is in the urinary tract. So if it's in the urinary tract, we don't necessarily know gram-positive or negative, but a lot of times urinary tract is infected by gram-negatives because that's where a lot of times those bacteria are hanging out. It's not completely always true, but most of the time you'll see more gram-negatives affecting the urinary tract and the GI. Facultative anaerobe versus strict anaerobe or aerobe. I would say probably not aerobic if it's in the urinary tract because there's not a lot of oxygen hanging around in the urine. So I would probably eliminate D based off of the fact that this one would require oxygen. If it was a respiratory bug, then I would say, okay, maybe it could be an aerobe, right? Because we're going to be in the respiratory tree, getting lots of oxygen. But given this is in the urinary tract, I'm going to eliminate this one. Pure pathogen versus normal colon flora, you might not know that with Proteus, so we might skip that option. And then modal or non-modal. A lot of times, if we're dealing with urinary tract, they have to swim in there. So a lot of times, our urinary tract bugs are going to be motile. So that gets me then down to A and B. So by just knowing, by being able to logic my way through, it's probably not an aerobe because it probably doesn't have a lot of oxygen where it's at, and it's probably motile. I'm able to get to a 50-50 chance, even if I know nothing about the bacteria. Then if you know gram-positive or negative, you're there. Yeah, I saw your hand first in these ones. The kind of the gut or the urinary tract, they're just more commonly associated. They tend to be more of our trickier bugs to get rid of. So when we talk about GI infections, we tend to see more gram-negative GI infections. Our main two gram-positives are staph and strep. So, and then bacillus, which is a spore-forming bug, but we don't see as many bacillus infections. It's not impossible, but you don't see that as common. So when I'm thinking of our gram-negatives, I'm thinking non-respiratory, non-skin, so typically gut and urine. Think of there as like our enterococcus bacteria. I saw hands over here. Yeah, absolutely. So next week, next week, Monday is going to be all about the immune system and micro. So next Monday, that's the whole day. So we will get a lot of that happening there. Probably the best thing I have for you is trying to create for yourself, like I've mentioned a couple times, a dichotomous key where you're really like starting with what are all the major bacteria players that could come up on an exam like this. So getting a list of all your streps, your staph, your E. coli's, your proteus. So looking into even just what are bacteria that commonly infect the body, and then putting them into categories of gram-positive, gram-negative, and coming up with some type of acronym for yourself to help separate the two. There are some that are already created, like there's the HACK acronym for gram-negatives, but it includes some gram-negatives that aren't super common. So I encourage you to create your own list and come up with your own memory device, or work on actually drawing out your dichotomous key in a way that you can remember. That will help, I think, more than just trying to use a pre-made mnemonic that won't really represent what we need to know in this test. Yeah. And I always try to associate with a condition or a person, right? I try to create that picture in my head of like this little bacteria that's swimming around, that's coagulase positive. Like I create my little staph bacteria in my brain. That's a little human that has a story. That tends to help the most. But we will do a lot of micro next week. Yeah. This is an example of a mini dichotomous key. It's kind of what I was mentioning here. So this shows you some of your gram-negs. So it has different shapes that they could be in. There are a few that are aerobic, but again, more rare. They have some coccobacilli, they have oxidase positive, again, different tests, lactose fermenting. Some of these are more helpful for actually a microbiologist, right? So don't feel like you have to memorize this or understand it. We will simplify it for what we need to really know, because you aren't microbiologists, you're doctors, right? So you don't need to know every single microbiologist test. All right, sore throat may indicate tonsillitis. Which tonsils are located between the palatoglossal and the palatopharyngeal arches? Palatine tonsils, they kind of gave it to you, right, with the name. But if you don't remember, here's your arch, and your palatine tonsil, and your palatine tonsil. It's your arch, and your arch, and your tonsil. Your arch, and your arch, and your tonsil. Can you see my pointer? Okay, good. It's like, am I just pointing to myself? Great. Which of the following is true regarding shingles and chickenpox? This question is interesting. All right, chickenpox and shingles are different viruses that infect the body in a similar manner. Nope. Shingles can only occur in patients who have already experienced chickenpox. Kind of. Chickenpox is more severe in children. No. If you haven't had chickenpox, it is safe to come in contact with someone with shingles. No, right? You could still catch the same virus with someone with shingles, even if you haven't had chickenpox. It's a contagious virus. That's why I don't love B, because yes, in theory, if you haven't had chickenpox, you can still get shingles, because you can have a chickenpox vaccine and you can still get shingles later on. So I don't love this question here. That's why we have a shingles vaccine, right? There would be no point in giving anyone a shingles vaccine who's been vaccinated for chickenpox if this was fully true. So this is the best answer of these four, but it's not a 100% true answer. Yes, absolutely. So when I'm thinking about, yes, they do. So I'm thinking about this one though. This one is saying essentially, if I haven't had chickenpox, I can go hang out with someone with shingles, which I know public health wise, that's not a true thing. I shouldn't just go hang out with a shingles person. So that's probably not going to be my correct answer, even though it's kind of saying the same thing as B, which is shingles can only occur with patients who've had chickenpox. This has definitely been on the NPLEX. I definitely wrote a passive-aggressive comment about it when I answered it on the exam. My NPLEX exams are full of passive-aggressive comments to the question writers. It's not great. I had that question. It was not ideal. Okay. It is now, you can find it on Wild Brilliance. You can find these on other places, right? Some of these questions are included in different like NPLEX study guides, and these are questions that are out there. This is not like proprietary information that I'm giving you. But yes, I have this question on the exam, and I wrote a paragraph of rage. Yeah. Which of the following viruses causes mono? Epstein-Barr. This is one that we should probably know as NDs. We talk about Epstein-Barr a lot. If you don't, now you know. Herpes simplex 1 is latent in what? And varicella zoster is latent in what? This is knowing where these guys like to hang out, guys or gals, like to hang out. And so herpes simplex likes to go into the trigeminal ganglion, and varicella likes to hang out in our dorsal root ganglion. So this is just knowing somewhat about this viral life and where it likes to chill out in the body. Other ones that you should probably know, Epstein-Barr would be a good one to recognize where it likes to stay in your B cells. Sorry. That's my big dramatic pause. I was thinking if you need to know any others. Maybe I would say Epstein-Barr, herpes, and varicella zoster would be the three they would probably ask this type of a question of where it could lie latent or dormant. And then last but not least, our CHF person. So which of the following clinical presentations would you expect if you had right-sided heart failure? This isn't all the above, right? We talked about this on Monday, so you should know all these things. JVD, hepatosplenomegaly, edema. So all of the above can happen when we have right-sided heart failure because blood gets backed up, and it's going to cause swelling to everything on that right side of the heart. This one's a little bit trickier. Which of the following organisms is a common cause of viral cardiomyopathy, which could result in CHF? This is like, what? There was like 12,000 different etiologies for viral cardiomyopathy. How do I choose one? Well, we rule out rhinovirus because rhinovirus is not likely the cause. We haven't seen that as an etiology for really anything heart-related. Hep B, we haven't seen either as any cause of a cardiomyopathy. So then you have HHV6 or Coxsackie. I'd say when in doubt, choose Coxsackie. It tends to be the virus that affects the heart stuff the most. So if you have a guesstimation to make for a viral cause of some heart-related something, choose Coxsackie virus. V6 can. Yes. Rhabdo. Yep. Yes, absolutely. That's fine. All you need is a couple letters and then you're good. Rhabdo. Yep. So Coxsackie, I would say when in doubt, choose Coxsackie, but there are other viral causes. So know that you could be given one that's one of the randoms. Remember I said I had leprosy on my NPLEX one. When have I studied leprosy? Never. So anyways, but they also say other documented causes and they list all of them here. So you can see obviously many, many causes of viral dilated cardiomyopathy available, but Coxsackie is the most common of the viral causes. What are the following are the most likely causes of a CHF? So we have two risk factors together, right? This is where I told you they'd do this. They put a bunch of really good risk factors, but they'd only have one that had two good ones together. So they have diabetes and hypertension. That sounds good. Hypertension and hip osteoarthritis, no. Type 2 diabetes and psoriasis. I haven't heard psoriasis being connected directly to CHF, so I'm going to get that one off. And psoriasis and hip osteoarthritis, no. Now, could an autoimmune condition maybe set you up for a heart condition later on? Absolutely, but it's not as direct of a cause as diabetes and hypertension, so that's our best answer, right? Don't make it too confusing for yourself. Choose this horse, not the zebra. Which of the following explains why edema develops in patients with CHF? Is it due to inappropriate parasympathetic activation? No, that doesn't make sense. Increased aldosterone, that's increased sodium and water retention. That makes sense. Increased thirst leading to increased excessive water intake. That doesn't really compute. Although yes, if you drink too much water with CHF, you can get fluid overload. Or inappropriate ADH secretion resulting in higher sodium retention. That one also sounds really good, but again, at the end of the day, it is your increased aldosterone, increasing sodium and water retention. I'd say if you don't know which hormone to choose, this one just talks about sodium, this one talks about sodium and water. So I would go with this one since you know edema involves excessive fluid in the tissues, not just a sodium imbalance. Aldosterone is your best bet. You also, if you knew that spironolactone is a treatment for CHF, spironolactone can help decrease that excessive aldosterone, therefore decreasing that sodium and water retention. That will come later. And then lastly, if you know how to draw your box, you know this. It's correct sequence of blood flow, right? Atrium, tricuspid, ventricle, pulmonic. So C is your answer. And now we got through the test. If you got more than half right, you're doing well. So if you got more than 50% right, you're already ahead of the game. If you got less than 50% right, that's fine. I encourage you to take it again in a couple weeks. before the test. See how you do. You will get better. It'll give you confidence. You'll get used to these questions some more. Yeah. Yeah. It totally changes. For me, I was neurotic, shocker. And so I went through I gave myself on each question a star if I 100% knew it was right. Like I didn't even need to try. Like a check, I think, if I was pretty right, but and a circle or like a frowny face or something negative if I like had guessed. And then I like calculated every single time. I think mine, I had about 62% that I felt really good about. And then the rest were kind of like guesstimations or not, and I passed with flying colors. So typically they'll say 70% or above, but they'll throw out a good chunk of questions. So I'd say if you're getting above 50% on your practice test, you're doing good. If you're getting into the 60s or 70s, that's excellent. If you get above that, then no problem. This is a like C's get degrees situation for pass NPLEX. This is not an A perfect score type situation, right? So throw that out the door. You did that in class. This is a get through. And know too that if you are really great on just one area but not good on the other area, you won't pass, right? You need to have an adequate generalized amount of knowledge of everything. You don't need to be necessarily excellent in any one thing. But you can be better in some areas than another. Like I sucked at embryology when I was younger. Ironic that I teach it now. I don't know how that happens. But so that I was not confident on that section, but it didn't matter because it was a small portion of anatomy, and I was really good at anatomy. I was an anatomy TA. So I was like, oh, I got anatomy, so I'm okay that I'm not so good at embryology when I took this test. And I was really good at path, and I was really good at micro, but I was not great at immuno at that time. But I felt okay because I felt like I could justify like my path score with my path and my micro. So those type of things, that's fine. If you feel really confident in an area, that's okay too. Like lean into that area and really feel good about it. Make sure you have some generalized knowledge in your weak spots, but don't necessarily like waste all your time trying to become excellent in an area that you're not so great at. Okay, I want to take a break for y'all. This is a lot, so we need to take like a brain break. So let's do like a 10-minute. So 10:40 will come in. We're going to finish up our cardio and our pulm today. And then we'll meet back again on Thursday and do endocrine. And then Friday we'll do GI. And then next week we'll get into our immuno and our micro. All right, online we're going to take a 10-minute break.